This is the case of PDA. You see in this image parasternal short axis view. From right to left, if you try, this is right pulmonary artery, this is left pulmonary artery, and this one is PDA. So whenever you find a 3A structure, most lateral one is PDA, most left one is PDA. And in case of pressure on both sides means on aorta and on pulmonary artery, almost same, then there will be no flow, or flow will be bidirectional, but there will be minimum flow. In that case, you have to depend on the anatomical part only. That is what it, then you have to understand that how the PDA looks, where the PDA has to be present. So this right pulmonary artery, left pulmonary artery, and then this is PDA. Now see, the flow is bidirectional. This is flow, blue in color, that is flow towards from pulmonary artery to aorta, that is responsible for cyanosis. Then this is red, this is red flow. Then here it flows from aorta to pulmonary artery, red normal flow. This red normal flow, blue is abnormal flow. Flow is this red flow, that is normal flow, blue is abnormal flow. The flow is bidirectional, right to left and left to right also. That flow from pulmonary artery to aorta, that is abnormal flow. A flow from aorta to pulmonary artery, that is normal flow. So whenever pressure on the both sides is almost equal, then flow becomes bidirectional. In some part of cardiac cycle, flow is higher on the right side, and from right to left, flow then becomes higher on the left side, and flow is from left to right. So this is bidirectional flow. In this case, what I want to stress out, that whenever you find very low flow PDA, in that case anatomy has to be remembered properly. From right to left, first you will get right pulmonary artery, then left pulmonary artery, and then PDA. The PDA is the most lateral one that you have to remember in this case. LVs, you see this LV is almost D-shaped, that indicates RVSP is quite more, that RVSP has become more in this case, that's why LV is becoming D-shaped. You see the flow is very less and flow is bidirectional in PDA. This is RPA, right pulmonary artery, this is LPA, left pulmonary artery, and this is PDA. So from right to left, RPA, LPA, and PDA. PDA is most lateral one. So this is the case of persistent pulmonary hypertension of newborn. Baby is only 2 days old. LV chamber is D-shaped, suggestive of increased right ventricular systolic pressure. PDA has bidirectional flow. In this case, a very small ASD was also present, that also has bidirectional flow. So almost this is the ASD, size of ASD, very small ASD. So ultimately this is the case of persistent pulmonary hypertension of newborn with PDA and very small ASD with bidirectional flow. So normally in this case you have to find out clear cut velocity of tricuspid ejection jet. Only that you can say how much the RVSP is present. So RVSP has to be decided correctly in this case, and you have to quantify the exact size of PDA also. PDA has two ends, one end is pulmonary end and another end is aortic end. You have to find the size of both ends. Normally in this case, if the pressure on right side becomes less, that is persistent pulmonary artery hypertension becomes less, then PDA also closes. The main treatment is to reduce the pulmonary artery pressure. Thank you.